pretty vague, and there's a lot of surgeon preference, but I was just trying to think, well, what would be good kind of from a nursing standpoint. So I hope I hit, just so when you call us, or what should you be calling us, or what information do we want on our general surgical patients. And I kind of divided into, I guess, kind of more two. The first 5 things are kind of things sticking in the patient, coming out of the patient, on the patient, versus the second 5 things are things directly, you'll do with the patient, or, more between you and the patient versus you and a device. Maybe that's a way to put it. So the first thing I thought about is NG tube management. And, why do we put an NG tube in? And it really depends on the surgery and what we're doing and why we're doing that procedure. Anybody who you think is at risk for nausea, vomiting, ileus, not going to do well with their bowel function after surgery is going to get an NG tube. And the patients coming up to surgical step down are no longer intubated, but if somebody has a bad bowel obstruction or a lot of contamination during their surgery, they're expected to have a prolonged ileus. So those kind of patients are going to keep an NG tube, put an NG tube and keep the NG tube in. So another, why should NG be on continuous, low intermittent, clamped? When do we decide that? It's a little bit surgeon preference. Some people want the NG continuous. I like it personally low continuous. Some patients like surgeons like intermittent. I don't know, I feel like you're sucking and releasing the stomach wall, every time it goes on, but that's just the way I was trained. Everyone's kind of been trained differently. I don't think there's a right way or a wrong way. That's really preference. And how long should it stay in? It depends what type of surgery a patient had. So if somebody had gastric surgery, stomach surgery, I tend to leave an NG tube in longer. So someone had a perforated ulcer in their stomach, you want to have that hole in the stomach heal because the NG is going to decompress the stomach. And you want to let that hole heal before you pull that NG tube out. So for me, when I do gastric surgery, I usually leave that NG tube in 4 to 5 days. I really want it healed, and a lot of times I'll get an upper GI study and make sure there's no leakage from the stomach before I pull that NG. And a lot of times colon surgery, people won't put an NG tube at all if it's a quick and easy colon surgery. I usually do an NG overnight just because a lot of people can get nauseous from the anesthesia, so colon will be less so. But if someone has, again, peritonitis or ileus, for any reason, they're going to have that NG tube in longer. And then some people, before pulling it, will like to do a trial of clamping. You clamp the NG, it's kind of like the NG's out and see how the patient does. If you do okay, you pull the NG tube. So I think NGs, again, everyone's a little bit different, but you have to think about why is it in before you're pulling it out. So Foley catheter, obviously, we put it in for patients who have had a longer procedure. Sometimes it's hard to predict, but around 2-3 hours, I think we think about a Foley catheter in the OR. And really, it's for these patients who are monitoring their eyes and nose, or they're too sick to get up initially and get out of bed. So one of the things that I think is really important is when their urine output's low. And what is considered low? So we want to know when someone has low urine output. So most patients should be making ½ cc per kilo per hour. So if you have a 70-kilo person, they should be making 35 cc's per kilo per hour. So little old lady who's barely 100 pounds, I don't really care if she's making, if her urine output's like 20 cc's, 15 cc's an hour. If it doesn't look concentrated, you got to look at the quality of the urine. It doesn't bother me so much, based on their weight. But again, simple things. Why is their urine output low? You want to make sure the Foley's not clogged. Does anybody flush Foley's anymore? That's kind of the first simple thing is let's flush it and, like back to your roots, right? Let's flush the Foley and make sure it's not clogged. But then the next question is, why is their urine output low? So post-op patient, are they volume depleted or are they bleeding? So you've got to examine and look at both of those things, And hopefully when you call somebody, they'll kind of make that assessment on the phone. Do they need a hemoglobin check? Are you concerned about bleeding? Do they need a fluid bolus? You know, so those are kind of the immediate post-op reasons. And 3 to 4 days later, patients should start mobilizing their fluid and diuresing. If their urine output is still low, then we start talking about diuresing the patient. But the other thing is, if someone's urine output drops off suddenly, is there something else that can be an early sign? Are they getting septic? Is there something else going on? So, you know, it's a really good indicator kind of what's going on with the patient overall. The best kind of general surgery patient, when we do a big belly case, is you kind of are resuscitating them for the first couple days, and then on post-op day 3, 4, they start diuresing and they do it on their own. So we're always like, wow, that's great, good sign, they're getting better. It may not always be appropriate to DC the folate, you know, per pos. What's the hospital protocol?
40 hours.
Yeah. So I think if a patient's on the edge and still kind of requiring resuscitation, it's really appropriate to ask the surgeon, do you want the Foley out or not? I know it's hospital protocol, but sometimes it drives me a little crazy when the Foley's pulled and I'm like, wait a second, we're still resuscitating them and we're still giving the fluid. Or if someone really isn't getting out of bed, I just think it's kind of mean to pull their Foley. I don't know. I don't know what the risk of keeping it one more day versus the risk of infection, but if someone really isn't able to get out to pee, I mean, I just as a personal measure to have someone sitting, you know, in a pile of, a pool of urine is obviously uncomfortable. So, okay. But if there's any concerns, I think you can't lose by asking the surgeon first. You know, is it time to pull it? Do you mind? Hospital protocol says we're supposed to pull it. Do you mind? Okay, next thing on the patient is the dressing and the wound care. And it's it's surgeon preference. Usually most surgeons don't like the dressing change in the first 24 hours. But for some reason, I always write for dressing changes, and that order is just not picked up, I found. And I don't know why that is, so that for some reason the dressings aren't getting changed. And for a wound to be sitting in a saturated dressing, it can macerate it. It just doesn't do that wound any good. You really want a dry, clean dressing. But I think even in the first 24 hours, if there's some, you know, drainage, some people reinforce. My preference is just take it off and put a new dressing on. Like, why are you going to take a wet dressing and just add ABDs on top? You know?
At what point do you want to be called, like saturated, bloody saturated, or just?
Yeah, bloody saturated. Okay. Absolutely.
We work at night, so it's like, you know, I agree with you. Take it down, see what's happening.
Yeah, and that's the other thing. You should see what's happening. What's the point of just adding more ABDs on it, you know? And if someone's bleeding, obviously we want to know. I think, you know, put tape on, make it easy for people to lift up and look under the next day when you come by. And the other thing that sometimes we do is pack, you know, leave it either open if there's a lot of abdominal contamination, we leave the wound open so it can heal it by secondary intention, or like I just finished a case where he has a perforated diverticulitis, so I do wicks and you hope that's going to prevent a wound infection. But, you know, again, hey, do you want me to start changing those wicks out? You know, I find nobody really asks me about that, or Witteroff's patients, you know, I'll be like, hey, these wicks have been in for 3 days. Is anybody changing these? You know, it just doesn't do a wound any good to sit with like goopy dressings and packing in it. And then I just wrote a side note, you know, and don't forget to change like central line around the drain. So many patients I've come down, that drain dressing is like goopy. It's been sitting there for days. I'm like, hey, change the drain dressing as well. Pick lines, all these things I think need to have be changed. I don't know if there's a protocol or it should, for central lines, right?
There'll be a
Central, but not for
regular
drains.
dressing.
Yeah, for JP
Now,
drains.
do you have a preference for the type of dressing or the type of tape that is used on your patients?
So I like just a dry dressing and just a paper or
Okay.
cloth tape.
Okay.
Yeah. something that's just easy to get up there and look under. And then,
Yeah, with the wicks, sometimes it's stuck to the wound. I don't know whether you want somebody to pull that comes along with the tissue that's healing. You know what I'm saying?
if it's wicked in
Yeah.
and it's really stuck,
Yeah.
Right.
then
Just
it
for
may-
normal saline, you want to
Yeah,
just for
I
normal
just
saline?
would put
Okay.
a little saline, moisten it up and pull it out, so, yeah. And it's hard to re-wick it, I mean, I appreciate that it's difficult, you know, but try to like just get a Q-tip
Q-tip.
and push it in there, so. And then just describing the wound, you know, is there drainage, is there redness, is there any dehiscence, meaning the skin is open or anything deeper, so. Okay, so I know you guys have asked me about colostomy and ileostomies. You know, these can be placed for a variety of clinical reasons. So it's, you know, colon perforations, we see a lot of that, diverticulitis, fecal impaction. But we'll also do a colostomy or an ileostomy if we do a, you know, a colon resection and we're not sure that hookup is really secure, or someone has been on steroids, or they have some other reason that they're not going to heal well, we'll do like a protective ileostomy. So that reason is to divert the stool and let that heal, and then down the road 6 weeks go back and take that ileostomy down. So there are a lot of different reasons, you know, why you want to do an ostomy. And, you know, so often we're doing these colostomies, ileostomies in more of an emergent situation. So sometimes you just bring the piece of bowel up where it's going to reach. It may not be where the ostomy nurse would like say, oh, this is the ideal location. It's not very often. I mean, I'm not a colorectal surgeon, but in my old practice, when we would have a planned colostomy, you could have the ostomy nurse mark the patient pre-op and stand them up and see where their pant line went. In these situations, you're in the OR and you need to kind of work fast, and you need to bring up that piece of bowel wherever it's going to reach. And sometimes it's in the left upper quadrant, sometimes the lower quadrant, you know, wherever you can kind of make it work. So it's not always ideal for the patient, but a lot of times you're doing a life-saving surgery. So when we look at the stoma, initially every stoma swells up and it gets really puffy, and that's normal. Nobody really cares if it's really swollen initially because they all retract, and you guys may not see that, but when they come to see us in the office, they're the nice kind of flat, pretty stomas, but they all look kind of swollen and ugly initially. But the things I think that you should call someone about is you know, if the stoma becomes dusky or black, it means the blood supply is being lost to it, so that's really important. If it's retracted, you know, then the question is it salvageable, or do we have to go back and fix it? Sometimes patients will have a peristomal hernia. Someone who's had a chronic stoma can get a bulge next to the, you know, so you'll have the stoma and then it'll really be bulging underneath. It's really generally not a problem for the patient. We just leave those. And then the other thing is just if there's a lot of excoriation of the skin, then we need to work on better ostomy care for that stoma, because they're getting, you know, we just gotta really protect that skin so it's not breaking down. I think the other thing just really to remember is when a patient ends up with a colostomy, it's such a life-altering event for them. And every patient needs colostomy care, colostomy teaching, the patient, the family, you know, just day by day to start on that as soon as they can kind of start participating in that teaching, so that when we're finally ready to get them out the door, it's not like, okay, goodbye, you're leaving tomorrow. By the way, here's an appliance, here's a bag, you know what I mean? It's too overwhelming for them. So I think the earlier we can start getting patients involved in colostomy care and teaching, the better. Okay, so drains. I thought I would talk a little bit about drains. The next thing we put in the patient, review the patient. So why do we put drains in? Some people love drains, other people hate drains. I tend to like drains. So a lot of my patients end up with drains. And you know, you put drains in if you think there's a potential that an abscess can develop. You can't always predict, but like this patient I just operated on, he had perforated kind of posteriorly, and he had all this contamination just on this one side of his belly. So I drained that side and I drained the pelvis, predicting if he was to develop an abscess, that's where it would be. Sometimes you do surgery and it's just kind of oozy, and you try to dry it up as much as possible, but they've been on Plavix or they've been on Coumadin, and they're just going to ooze. You can't keep it completely dry, so I don't want them to develop a big hematoma. I'd rather it drain out than get stuck inside and become an infected hematoma. Or if you want to drain fluid, for whatever reason, you leave the drain. So for me, the important thing is how much is coming out of the drain per shift, and the color and the consistency. And this is something I see, unfortunately, that is not well documented. So I'll look at the night shift and I won't see it, or I'll ask the day nurse. It's not always reported back. I'm not trying to blame any shift or anything, but a lot of times it just isn't well documented in the computer, or if I ask, nobody will really know how much is coming out. But I want to know how much is coming out. I want to know if there's a change in the color. So if it's clear and then suddenly it's coming purulent, sometimes you go in and the patients are sitting in the chair, they're sitting on the drains, you can't really examine it, it's really hard. So, if something has changed in the patient, I can't really see the drain. Like, I want to know if there's been a change. I try to always look at my drains, but, if something's now purulent, you want to know about that. For gallbladders, a rotten gallbladder, a lot of times they can get a bile leak afterwards. It looks clean at the time of surgery, and then 3-4 days when all the inflammation goes down, they'll leak bile from their liver beds. So suddenly bile's coming out of the drain. Like, those kind of things, you want to know if there's been a change. I always see it kind of provides a window as to what's going on in the abdomen. You get a clue if they're developing an infection or a problem. So, every general surgery patient, if they're operated on the morning, by the evening they should be dangle at the bedside. By post-op day 1, they should be in a chair. This is a really bad generalization, but a lot of these older people, I'm too weak, I don't want to get up. They don't, right? I mean, do you guys find that? And it's really, I always order physical therapy, but they'll come and then they leave. I'm like, what are you doing with them? You know what I mean? I think it's really you guys who are the core to get these patients up and motivated. I was reviewing the rates for DVT in general surgery patients, so without any prophylaxis, without any, heparin, Lovenox, SCDs, any of that stuff, is 10 to 30%. And the risk for a fatal PE in these patients is 0.2 to 0.9%. So they say PE is the most common cause of a preventable death for patients. And that's, I think, you guys, making sure their SCDs are on, making sure they're up and walking, making sure we don't forget to order heparin, Lovenox, some sort of prophylaxis. And it really helps them prevent DVT, prevent a pneumonia, helps their post-op ileus. It's just so good. And it's just getting these patients moving. They don't want to. I understand they hurt and they are uncomfortable, but it's so important for them. And it goes along with giving them their incentive spirometer. I can't tell you how many times I come in, no spirometer by the bedside. I'm like, what's your spirometer? Who brings them the spirometer? Is that respiratory? Is that nursing?
No, the nursing.
Nursing. Like, I think every post-op patient should automatically have it taped to their bedside. I don't know, but
I think they should be given it to pre-op.
yeah, absolutely. And when you have the opportunity to pre-op, a lot of times I will. We have on our pre-op orders teach incentives spirometer pre-op. So I don't know if they really do it or not in the pre-op holding, but there's a box to check. So if someone's having a big belly case, absolutely. Again, they don't know what to do. You got to teach them. I always say suck like a straw, breathe in, you come. I usually will have them test it for me. They're blowing out. I'm like, you're not, and they forget, a lot of them just don't remember what they're supposed to do. And then I say every time a commercial comes on, do a 3 big breaths. So, you know, again, it's just reminding them to do it. So, and of course, them ambulating and using their spirometer has to do with their pain control, because when you've had major abdominal surgery, you don't really want to take deep breaths in. So, you know, they're not going to be willing to do any of this unless we get their pain under control. Traditional pain meds are the narcotics, the Delray, morphine, Dilaudid, PCAs, but there's so many non-narcotic options that we have now, and I don't know if you guys are familiar with all of those. So Toradol, you probably all know, but Caldolor, Ofirmev, and these help prevent post-op ileus. So the less narcotics we can give, the better. I will frequently just write for 24 to 48 hours around the clock, but I think I do that because I'm not sure if I write for Ofirmev, if you're not familiar, which is basically IV Tylenol, if you're not familiar with that med, it may not be your go-to med. You know, you're looking for something breakthrough, or they're having a little pain, you reach for a narcotic first. But I think we got to try to get them on some of these non-narcotics, especially the older people who the narcotics can make kind of goofy, give them an ileus, you know what I mean, all the bad side effects. Obviously, some people are going to need narcotics. And the other thing I think that as a surgeon I try to do is use more stuff intra-op. So I used to use a lot of these pain pumps. Did you guys see a lot of those before? Where you, so the ortho, the on-cue pumps, where you have a catheter, you lie on the incision, it gives Marcaine. I think those are so-so. But now there's a new medicine called Exparel. Have you guys heard of Exparel? So I am using Exparel all the time. Exparel is I use it outpatient, I use it on these inpatient laparotomies as well. And a lot of the thoracic guys are using it on their thoracotomies. It's a long-acting local. So it's Marcaine, but it's released over 48 to 72 hours. So like when I do a hernia, they would all be in so much pain. Now people have almost no pain for the first 2 to 3 days. But I'll even use it on laparotomies, because like this guy just did, I'll infuse it, you can infuse it all around the area. So even though he's intubated, they won't have to give him as much narcotics, even though he's on a vent, and they can get him off the vent sooner. But I think what I'm seeing with a lot of these older patients, they're really not requiring a lot of narcotics when they use the Exparel. It's really great for them. So.
And the Caldolor, easy for me to say, Caldolor and Ofirmev, they're fantastic medications.
Right.
We use them on surgery a lot as well. And we find the majority of our patients, you know, you can cut the narcotic use in half,
Right.
at minimum.
Right.
So they are great.
Right. And Toradol I love, but you just have to be careful with the renal insufficiency. And Ofirmev, they have underlying liver disease, it's Tylenol, so you just have to keep that in mind. So post-op fever, this is like the traditional med student. We would ask what are the 5 W's for post-op fever, and the typical ones we say are water, wind, wound, walking in weird drugs or wonder drugs. So those are the 5 W's. So when we talk about water, we have to, so a patient now is post-op day 2 and they spike a fever. This is what rolls through my mind. So I'm gonna try to think about all these things. Do we need to send a UA? Have you looked at the wound and said, hey, the wound has some redness, or it looks fine? Are they the most common cause post-op fever in the first 24 hours is atelectasis? So are they using their incentive spirometer? Pneumonia? Do we need a chest X-ray? DVT and thrombophlebitis. I had a lady maybe 4 or 5 months ago who got, I don't know if you guys remember, she was about to go home and she spiked a fever, and she was a colon cancer, and she had a really bad thrombophlebitis in her arm. So it just yeah, she didn't speak English. She was Creole. So anyway, and surgically she was fine, and she had it really delayed her discharge for about 3 or 4 days till that resolved. And then down the line, we think of, if nothing else pans out, we think of drug reaction. For abdominal surgery, we think of abscess, but that's usually happens 5 to 7 days after surgery. So. And then feeding the patient. So, usually we feed the patient when the gut starts functioning. Some surgeons, again, very surgeon preferential in terms of their approach. I really like to hear bowel sounds, and some surgeons say, oh, bowel sounds mean nothing. I don't believe that. I really think when you're hearing bowel sounds, things are working and active, and I like to see a patient passing gas. So I'm pretty conservative. I used to try to be more aggressive, and then I found they all got post-op ileuses, and we'd just be sitting around for days and days. So for me, when someone's passing gas and they have some bowel sounds, I'll start them on clear liquid, and I do a slow advancement. If someone had really rip-roaring peritonitis during their surgery, even an appendectomy where they had a perforation, it's going to take their bowels longer to wake up, and just always remember if the surgeon, their NPO and their NPO and their NPO, hey, is it time to start some TPN and give them some nutrition. And then the last comment I say, I think just physicians love it when the nurse is there and you communicate. So if we're making rounds, to be available, to see the patient with you. A lot of times I'll think of things and I'll say it and then I'll forget. We're just always running, always distracted, and I'll forget to put the order in, and then you'll get things like, hey, did you want this? So it's just so great for communication. And just knowing the details, what's the urine output, what's the drain output, I think it's better for communication, patient care, and getting these people better. So, just cover
very
things.
helpful. Thank you so much.
Thank you.
Thank you very much. What questions do you guys have for her that she didn't cover?
What's the win in post-op there?
Pneumonia, atelectasis,
Okay.
breathing.
What's the-
Yeah, that's what we always ask our medical students. What are the 5 W's for post-op fever?
Well, is there anything specific to our unit that you're seeing that you're not happy with, that you'd like us to change?
No, I think you
or-
guys are really getting better. I mean, I feel like I've seen a lot of improvement.
You were actually the first physician to send us bellies. So, always before it was the spines, and before our unit changed, it was cardiac. So to start getting bellies was a new thing for for the staff. So they've done a great job with addressing the needs. But we felt like if there were specific things that we're not doing, or specific things that they just maybe don't even know, that it was just better to hear it from you.
Yeah,
Because we want to do what you want us. I mean,
Yeah.
we want the
And
best
again,
outcomes
it's
for the
hard.
patient.
Every surgeon has their own
Absolutely, of
preference
course.
and whatnot. But
Of course.
I hope these are kind of things you guys are seeing.
Absolutely.
I don't know.
I know, some of the questions that I had heard from people specifically were, related to the dressings and things like that,
Yeah.
and all, so.
It's very surgeon preference. I just don't like goopy, old dry. I like fresh, clean, dry dressings every
Sure.
day.
Well, and now we know that you want them changed within 24 hours, that's good, because some surgeons are like, don't touch my dressings till I've seen them.
Right.
So.
Right.
So that's good to know.
Yeah.
All right, perfect. Anything that she didn't cover, guys, that you want to know while we've got her here? No? All right, well, thank you so very much.
Thank
We
you
appreciate
guys.
you.
Thank you.
This is
Thanks,
very
everyone.
informative.
I really appreciate it.
Just since I work at night, just so we're on the same page, in terms of if they spike a temp in the middle of the night, what's your cutoff? Like, at what point would you want to be notified?
Like 101.5
Okay.
is most common, or 38.5. That's when you'd start, getting chest X-ray culturing, all that kind of stuff. So it's a good question.
Just trying to save the calls for nights.
I know.
That's
I
why
don't
we
mind
can
calls
leave.
at night. I may not be awake, but I don't mind calls.
Well, since we did the video, we'll be able to make sure that the staff that's
Thank you
working
very much.
during this time frame will be able to see it too, so that everybody will get the same information, the same message. So, thank you again.
Okay, sure.
Thank you.
Thanks, guys.
Okay, take care, everyone.
If there's ever anything.